Now, you know, I wouldn't miss this meeting for the world.
No, and Mo, we just went live. The doctor is in. You're right on time, girl.
Look at all these song stars. Listen, I ran from my car. I am here and I'm tuning in for the show because I'm like a fly on the wall while we talk about this. So we might be the hosts on the flyer, but this is your show. We're
I know.
excited.
I know. We're so excited. Such an important topic. And we have an amazing crew. Jean called me, I don't know, a while ago and said, can we, talk about No One Missed? And and we have our Dr. Maida. So I'm going to let you guys introduce yourselves and then we'll get into this conversation. And, I already just kind of warned Dr. Maida that, we need words we could spell. And I don't know who knows what biomarkers are and why they're important. So this is such a hot topic and such an important topic, especially if you have metastatic breast cancer like these amazing, beautiful, badass women. Bless. So, well, Eugene, you want to start the introductions? And
Sure. Well, we're so honored always to do anything with the two of you. So thank you for having Living Beyond Breast Cancer and the No One Missed campaign on the Doctors In. We're really excited. I just wanted to sort of set it up to let you know that we kicked off this campaign in late June. And the goal of it is really to raise awareness for those people living with metastatic breast cancer about the importance of biomarker testing and really understanding what they need to talk to their doctor about to make sure they get the best, most personalized treatment. So I think we have a great panel. So I want Dr. Maida, why don't you introduce yourself and give us just kind of what is biomarker testing, and then we'll bring these advocates in to talk about their experience.
Sure. And thanks again for having me on this. So I am a medical oncologist. I've been an oncologist for about 18 years now, and for most of that time have been treating breast cancer. I am currently in practice part-time at the MD Anderson Center in New Jersey. So that's MD Anderson at Cooper. It's in Camden, New Jersey. And about a year and a half ago, I decided to make a bit of a career move. And I'm also the medical director of a startup company called Reimagine Care, which is looking to improve the experience for patients on treatment. Do you want to introduce everyone else, or do you want me to go into?
Yeah, start it off.
Okay. So as we were talking about before, the biomarker, there is a lot of confusion about the biomarker and what it means. And I think you'll sort of hear across the board lots of different definitions for it. The way I think about a biomarker, so it is essentially something that we can measure either in the person or in the cancer that will tell us about the behavior of the cancer and about what sorts of treatments may or may not work. And I think that's probably the simplest definition of it. The types of things we're measuring vary. There's lots of different kinds of biomarkers, which I'm sure we'll get into. But I think that's a good kind of overall definition of what we're, when we're talking about biomarker to patients, that's what we're referring to.
Great. So Amelia, do you want to talk about your experience with living with metastatic and biomarker testing?
Thank you. And thank you for having me. I was initially diagnosed in 2019 with HER2 positive breast cancer. At the time, it was already metastatic. So it was a super aggressive cancer at the time. Thankfully, doing really well. 5.5 years later, no issues. I was very fortunate that from the outset, my doctors did a lot of what you've described, Dr. Maida, that they did that as part of the natural routine of all the tests. So in addition to all of the predictable pieces, the scans and all of the biopsies and whatnot, they also did all of the biomarker testing because they then knew how to target what I was showing. And I was, completely at the time HER2 positive, ER/PR negative. So for me, the experience in that regard was a favorable one because they were so ahead of that process. It was already part of their existing protocol. I did not have to explain it to them or ask questions as to, is it happening? Is it not? they were already in that process. And they continued to do that throughout. Unfortunately, the first 18 months, there was progression. Every treatment was failing. And they continued to look at it constantly to ensure, is there a mutation happening or not? There wasn't. It was just not responding to treatment. But they also added the component of that as part of my routine blood work process. And I would love for maybe you to clarify a little bit around that as part of when you're going as an ongoing metastatic patient and your routine blood work happens. They also added the biomarker blood work elements to it. So in addition to the the CDC and plus DIF and the CMP, they also check those as well. And I don't think a lot of patients necessarily know that. And I'd love to hear more about that. So that's my story.
I want
Yeah.
to hone in a couple things you said, Amelia, which is one, it sounds like your doctors were advocates for you, right? Because they included some of these things as routine, where in some areas they might not be as routine. But I think also there's a distinction between early stage and metastatic disease and how biomarkers are used and when they're introduced. So we can let Dr. Mehta talk about a little bit of that too. And Gina, is it whatever order you want to go in? I'm just putting a pin in this so that we can talk about early versus metastatic. And then how do we get doctors to do what your doctor did for you, Amelia? Because I think that should be the norm, and sometimes it's the exception.
Exactly.
Can we go back for 1 second? You know, I'm like the 5-year-old here. I'm stuck on what a biomarker is. So is a biomarker HER2? Like,
So let's,
is it
yeah.
a subtype of biomarker? Is your
Mhm.
subtype? Okay.
So the simple answer is for that question, yes. But a biomarker is also a lot of other things. And I think Amelia's story, I just want to touch on a couple of points. One being, so you were diagnosed 5 years ago, is that right? 2019.
Yeah.
And I think about the progress that we've made in the last 20 years since I've been treating breast cancer. And 20 years ago is actually about when that one particular biomarker, HER2, was really starting to get a lot of attention. And they're the first drug, the first kind of targeted drug in breast cancer, first antibody in breast cancer was developed around HER2. And the last 10 to 20 years have seen a real shift in our understanding of the biology of these cancers and the way to attack them. And so to answer your question, Ricky, around, that going back to what is the biomarker. So again, there's lots of things we measure in breast cancer patients. Some of those things we measure in what we call early stage breast cancer. Some of those we measure in what we call metastatic breast cancer. Now that distinction, early stage and metastatic, what's interesting about breast cancer and why I love treating breast cancer is that distinction is starting to get blurred. If you go back a few years ago, the line in the sand was pretty clear, where you have stage 0, you have stage 1, you have stage 2, you have stage 3, and then the line, and then you have stage 4. Stage 4 is another way to say metastatic breast cancer. What that means is that the cancer has traveled outside the organ where it started and gone into another organ. And in the past, we always looked at metastatic breast cancer as this incurable thing that treatment was meant to prolong life, improve symptoms, but in the end, we were not going to get rid of it. With the advances in the treatments that we're seeing over these last few years, and Amelia is a great example of this, HER2 is actually probably the single best example of this in probably all of solid tumor oncology. That idea of metastatic and incurability is now no longer always connected. I have patients like Amelia who are 5, 10 years later who are doing great, whose scans are clean, who are feeling great, who remain on treatment. We're almost at the point where we're questioning, at what point do we consider stopping treatment because the patient's fine? And those are conversations that we're starting to have with our patients. So going, what was that?
Isn't that awesome?
Oh, it's amazing.
Is that because you're treating based on the biomarker?
Correct. So there's certain biomarkers. So the first biomarker was actually the estrogen receptor, ER.
Right.
So that was, we've known about the ER for decades. And there was a drug called tamoxifen, which was designed in the 70s it was really the first targeted drug in all of cancer because we found a target and then designed a drug to go after that target. And so ER, PR, HER2, those are biomarkers. Those are biomarkers on the cancer itself. So every single breast cancer diagnosis in this country should have those three things checked, period. It doesn't matter where you are, what part of the country, what center, large, you're at Mayo Clinic or you're at a 10-bed hospital in the middle of nowhere, that at the very basic level, those three things have to be checked because those three biomarkers are actually both prognostic, meaning they tell you about the behavior of the cancer, and predictive because they tell us about what treatments might work or not work. So those are really important biomarkers, but by no means are those the only biomarkers because once a patient starts on treatment, depending on their stage, depending on their situation, there's lots of other tests that we're doing. And I wanted to kind of touch upon this idea of, you said mutation, Amelia. That's another word I think that gets thrown around a lot. What does that mean? You hear the word mutation.
What does that mean?
So mutation, so to get back to how the central sort of how life works, DNA to RNA to protein. So the DNA is like your blueprint. And then proteins are the actual things that do stuff in the body. So the DNA is the blueprint for those proteins. So when we talk about mutations, we're actually talking about the DNA of the cell. So the DNA is where we have these genes, and there's about 30,000 of them. Every cell in your body has about 30,000. Now, obviously, not all those genes are on it all the time or we'd explode. And so certain genes are on at certain times. And so that determines what that cell is going to do. It could be a hair cell, it could be a skin cell, a liver cell. And the same goes with cancer. When certain genes are on and certain genes are off, it directs the behavior of the cancer. And so we now have the ability over the last, again, about 10 to 15 years, maybe really the last 10 years, to look at genes in a broad way. In the past, the only way we could look at genes was one by one. So it took forever. It was really expensive. The technology wasn't great. But in about 2013, there was the technology changed significantly into this new platform called NGS, Next Generation Sequencing. It's this really cool technology where you can look at hundreds of genes at the same time. It's not expensive. And so that really ushered in this new era of looking at mutations in genes and using those mutations to start changing our treatments and guiding our treatments. And so genes, your genes are what we call genetics. The cancer's genes are what we call genomics. So you'll hear those two words thrown around a lot: genetic testing, genomic testing. Genetic is your genes. That's the genes that mom and dad gave to you and that you could give to your kids, and half of which your siblings might have. Those are important for you, for your family, sometimes for treatment. Genomics is just about your cancer and the genes of your cancer and what sort of treatments may or may not work.
Ricky,
I'll stop there. I could keep talking.
think machines in a factory, right? We used to have to take apart the machine to find out what was wrong with it. And the best analogy I use is that episode of I Love Lucy where she and Ethel work in the chocolate factory, and all of a sudden, you got chocolates flying off the conveyor belt, right? Something's wrong with that machine, but not all the factory mistakes or machine mistakes get passed down generation after generation. And you no longer have to take apart that one machine to find out. You can figure out what's going on in the whole factory and all the machines. And so it's kind of this broader way of looking at things that makes it really exciting for us and confusing for you. But it gives us a better idea of what's happening inside that factory that makes the products do what they do or do what they're not supposed to do.
Yeah. So why wouldn't you look at this? Like, to me, it's like, why would you even have a treatment plan without this?
Yeah, it's a great question. There will come a time, probably not too far off in the future, where every single treatment plan will look at this. Right now, it's about making sure that the information we get, we know what to do with. So, there's a lot of things we can measure. As there's all these tests out there. It doesn't mean we know what to do with those measurements right now. So right now, genetic testing, for example, we keep expanding that in terms of who's eligible for it, who should get it, especially since it became a lot cheaper to do genetic testing. A lot more women and men are getting genetic testing. I think there'll come a time where probably all women with breast cancer, which based on the breast surgical guidelines, any woman with breast cancer is eligible for genetic testing, which I think is absolutely the right thing to do. The genomic testing, we are testing more and more. I mean, just if I go back 5 years ago, the number of women I was doing that testing versus today, I think I ordered 3 of them this week on patients, and it would be 3 a month or 3 a year, years ago. So we're doing more and more, absolutely.
And we need to do it. We need to. So before we go, introduce our lovelies, my lovely blesties. But thank you for that explanation.
Yeah, Megan, do you want to share your
Yeah,
story? And then Betty?
Happy to. Thanks for having me. I'm Megan O'Neill. I was first diagnosed with early stage breast cancer back in 2015 when I was 30. No family history of breast cancer either. I always like to say that so that, that myth is dispelled out there. And I was about almost 4.5, almost 5 years with no evidence of disease. And on one of my blood tests that I was doing as kind of keeping up with checking my disease, it was elevated and I came back with a recurrence of disease. So I've been metastatic or stage 4 since 2020. I have, I was on one clinical trial and it didn't work very well. So I was on another clinical trial that just ended, but I was on it for like almost 3.5 years. So it was a great run. And so now I'm transitioning to another clinical trial next week, actually. So I'm between treatments. But when it comes to testing, I did have a lot of, all the markers done. I did have the CEA, CA27, 29, which are like specific tumor markers that show up in the blood, or little flags that show up in the blood so you can keep an eye on your numbers. But when I did specifically ask, I had one little spot that had been growing over time, and I was nervous about it. And I asked for specifically genomic testing, looking again at the cancer's genes. And we did find before I kind of grew out of that last clinical trial, or my cancer started expanding or spreading too far past the guidelines, I did find that I have the PIK3CA mutation, which I was not aware of. And, unfortunately, I don't know when I picked that up. And that's why, I'm such a champion for like getting that information, especially when you're first diagnosed as metastatic, making sure that you are looking at your cancer's genes just as much as you're looking at your own personal genetics. It's not really changing my course of treatment quite yet, but it is going to open other options for me down the line for clinical trials. It's just another way to sort of target my disease and make sure that I'm getting the best personalized care that I can possibly get. So I'm really, really grateful that we're talking about this. And I just want to make sure that everyone, especially the metastatic community, is aware and that they are getting tested and talking to their doctors about it.
It gives you options.
Absolutely.
And Doc, we know you have to go at 6:30. So if you want to like pipe in.
So yeah, I do. Actually, Megan, what you just a couple of things about what you said. The idea of surveillance. So there's a lot of questions around what happens when a woman finishes treatment, and what are we supposed to do? And invariably, we always get the question, how do I know I'm cancer free? And what are you going to do to make sure of that? And tough questions to answer because we're not there yet. If you look at the guidelines, they're sort of woefully inadequate in terms of what we do, which the official guidelines are, you don't do anything. You don't check blood work. You don't do any tests. You just see a patient, maybe twice a year, examine them, say hello, make sure they're feeling okay. And if there's a problem, investigate. And part of that is because in the past, it's the testing that we've had just hasn't shown to be good enough for results to make decisions for treatment. And so we've kind of taken this nihilistic approach to surveillance. Now, again, another thing that's starting to change. I will mention the tumor markers, which is actually what you had done, these specific blood tests. The reason we don't test them in a lot of women is that they're really not that specific to the cancer every time. So for example, some of you may know the PSA for prostate cancer. That test is a highly specific test. So if a man has prostate cancer, his PSA after he's treated should be 0. If it's 0.1, his cancer's back. That is not the case with the tests for breast cancer.
Wow.
And so there's a lot of these false elevations that cause a lot of anxiety, and we're not sure what to do with them. So you'll have kind of across the board some, I test them in certain patients that I think it would be valuable to do so. But what we're seeing now, and probably coming down the pike very soon, is a type of genomic testing that will be used in surveillance. So the official name is called CTC or ctDNA. It stands for circulating tumor cell or circulating tumor DNA. So we now have the technology to isolate little particles of DNA that are floating around in the blood, pick them up, connect that little tiny piece to the full DNA of the cancer, and then from there determine if that woman might have cancer floating around. And then the ultimate sort of holy grail being what to do with that information, start to use that to do testing and potentially even treatment. There's clinical trials right now going on that are looking at making treatment changes based off ctDNA. It's the first time we've ever done it that way. I mean, for 50 years, it's always been, you get a scan, CAT scan, a PET scan, and then you make a change. But by then, things might be a little later. It's better to make these changes earlier. So I think that is another place where patients really should, talk to their docs, particularly over this next, year or two, where there's going to be some really good information. Just at our national conference recently, there were some wonderful presentations, and there will be again at the breast cancer conference coming up in December about this topic. So this will be a really hot topic of conversation in breast cancer.
And so these are for people who have finished treatment for early stage breast cancer, and they want to do more than just sort of wait, right? So that's what they
Right.
talk to the doctor about.
So it's potentially for everyone, though. What's interesting is, yes, for surveillance for early stage, but also where some trials are using it to measure women who have metastatic. So a great example is Amelia's case, where she's had metastatic breast cancer. Actually, Megan, you too, where your tests might be fine. Maybe we look at ctDNA to see, is there really something going on a level that we can't identify, and use that information to either stop treatment or, so I think it will be used across the board. And just a few years ago, this was, futuristic stuff, but it's right here.
It's real now.
It's exciting.
So ctDNA, you can get that from a blood test?
Yeah, these are all blood tests. And that's what's great, is that you don't have
Really?
to do biopsies. You don't have to, we call them liquid biopsy. That's a term that you might have
Yeah.
heard. It's just a blood test.
That's awesome. I know when I hit 5 years, my doctor said, "Okay, Ricky, come back when you're symptomatic." And I'm like, what?
I know.
Not
That's
happening.
scary, because every symptom is cancer, right? You
I
think
know,
every
right?
eyebrow twitch and every toe
I
pain
know,
is cancer.
Every little pain you get, every headache. But
Uh-huh.
I know I just had my CA 125 yesterday. I just did the blood work for that. But yeah, we all want to know, you know what I mean? Like, I want to
I
know.
know, right,
Yeah.
right.
But I guess the more information we have, the better off we are, and we can make better decisions about our cancer. But go ahead, Betty, you introduce yourself, and then I have another question for that.
Yeah, well, hi, I'm Betty. I'm normally live in Princeton, New Jersey, but I'm here in Puerto Rico doing advocacy work. So I started off as inflammatory breast cancer in December 2015, and by 2016 I was metastatic, HER2 positive. So I'm still on my first line of treatment 8 years later. I
Wow.
feel very grateful for that. My PET scans and all my tests have been coming out perfect. I'm going to give myself a score of 99. Yeah, I feel really blessed about it. And thank you for describing about the CA testing, the tumor markers, that I've always wondered how accurate those things are, because every year, I get them tested constantly, and I'm like, how am I going to know? The other thing that I learned just recently is that, when it's metastatic, that doesn't mean HER2 is everywhere. when it hits another part of your organ, it could be a different type, a different subtype. It could be ER or PR. So I didn't know about that heterogeneity of cancer when it goes someplace else. So that really kind of shook me up a little bit. Because right now I'm on the same first line of treatment, so I figured I'm good right now on the Herceptin, Perjeta. But I'm definitely interested in something like the ctDNA, and I'm definitely going to talk to my doctor about that. And because from what I understand, cancer cells are like stem cells, are sleeping. And so I don't know what's going to stir it up. I'm 8 years, I'm not going to say cancer-free, but 8 years with no symptoms, and I want to keep it that way. But I also want to not give myself some false positive hope that it could be still growing in me. And I just want to keep tabs on that. So thank you for straightening that out for me. And that, yeah.
Yeah, that's yeah, thanks for sharing that. That important point you made about how cancers can evolve. And again, because of genomic testing, we've learned a lot of this, that when a woman has breast cancer in the breast, if you have a 1 centimeter tumor in the breast, it's about 1 billion cells.
Oh, by the way, Dr. Mehta, I had no tumor. It was
right.
just
You had
diffused.
Inflammatory, right?
Yeah.
Yeah. But I just mean in terms of the number of cells, we're talking billions of cells, but only a real small fraction of those actually have the ability to get out and escape and become the fugitives that cause trouble. And so what we realized, though, is the term you use, which is tumor heterogeneity. Kind of doesn't roll off the tongue, but that's the idea that these tumors are not like monolithic. They're not all exactly, all the cells are not the same. There's some cells that are a little different. And so sometimes the cells that escape are actually a little different. So we always, if a woman has an early stage breast cancer and then it shows up someplace else, it's really important to get a biopsy of that spot, because you're absolutely right. Sometimes the estrogen receptor can be different. The HER2 can be different. I've had situations where at the same time, the test on the breast and the other part of the body is different while it's happening in real time. And the genomics are different. And so, again, these are questions that we're all right now trying to answer. What do we listen to? That, you know, if you get a biopsy of something and a genomic test says A or B, and then the liquid biopsy says C or D, what do you trust? What do you listen to? What's, yeah, these are active questions.
Yeah, so
it is.
It's one of the reasons why in the surgical world, and I'll say the medical oncologists are so much better at interpreting and being a bit more fearless in ordering these tests, because the surgeons are thinking, well, what can I operate on? I don't know where the cancer is, and we have a positive test, and now this woman's gonna worry for the next 6 months that she's got cancer or that something's changing. And I've even seen patients who, you know, I will offer another biopsy, right? Maybe this tumor has mutated and we need more tissue to evaluate it again. And all of those things come into play, and they should all work together. But there's been a lot of fear in the medical community, and I'm so glad to see it begin to fade away as we get more data, right? Like, this is the era of precision oncology, and we can be as precise as we can be. We won't know everything. We can't know everything, but it doesn't mean we shouldn't look because we're afraid.
Right. We have more options to look. So I know you have to go, Doc. Can I ask one more question? You know,
yeah, please go ahead. Yeah.
Seeing all this data now.
Who's that with you? Your friend?
This is Harper. She's, you know, she every now and then comes on the show. She wants
to beauty.
So yeah, she's our mascot.
Look at her. Hamming for the camera.
Totally hamming for the camera.
Yeah, I want one of those.
She's my road dog. But you know, we're seeing all the science now that's showing that our Black breast cancer is different. Any impact on, you know, on that, and with this whole conversation about biomarkers, are we noticing any differences?
Absolutely. Yeah, absolutely we are. So as you probably know, it's only been really the last 5 to 10 years that we've actually looked at different ethnicities in the research. So if most of the trials that were done for years and years, the vast majority of women were primarily white, Caucasian. So the idea being one specific kind of genotype, you know, their genes are more similar. Asian women were different, Hispanic women are different, Black women are different. And so with a lot of the research that's been going on recently, we've uncovered some differences, particularly in Black women. We've known for a little while that the outcomes in Black women if you look stage for stage, tend to be worse.
Yeah.
And the assumption, which is partly true, was that it was an access issue, that women, they weren't getting to, which partly has certainly rings true, that there wasn't as much screening, there wasn't as much prevention. But actually, as it turns out, Black women with breast cancer tend to have the more aggressive subtype more often. Their cancers tend to have less estrogen, more triple negative. That's a subtype that's
That would be
more
me. I have
aggressive.
that. Yeah. Yeah.
Those are the cancers that kind of show up. We call them interval cancers. Those are the ones that show up even if you're getting your mammograms right on, every year. They show up 3 months after a mammogram. And because their behavior is different, they're more aggressive. They may need more treatment. And so the story is complicated in terms of why these differences are happening. We know there's differences on the gene level in Black women even with estrogen positive breast cancer. The type of estrogen positive breast cancer they have is often more of an aggressive subtype. And these tests around different genes are kind of showing us that. And so, what we're starting to see is that all the tests that we're doing around whether a woman needs treatment or doesn't need treatment are starting to incorporate these differences. And again, this is where I think, having a conversation with the oncologist, and really, to Mo, your point, like having this multidisciplinary conversation. These decisions shouldn't be just one doc making it. It should be a team. Breast cancer is a team approach. I've always felt, breast surgeon, medical oncologist, radiation oncologist, the genetics team, they should all be a part of these conversations, because there's just too much to know for one person to know all of it these days. And so we like the team approach.
Yeah.
Real quick before you go, pick 3. Can you explain? Pick what? Pick 2, pick 2, pick 4?
Yeah, pick 1, 2, and 3. Yeah, there actually is a other picks, but so think of it like, the way I explain it is if estrogen is like the river, and we put a dam on the river, all those estrogen blockers are like the dam on the river. The problem is the water kind of finds ways around. And so we have figured out some of those ways around. There's at least 5 or 6 different ways that we know of. One of those is through this PIK3C mechanism. So it's essentially a way that cancer cells, estrogen positive cancer cells, figure out how to bypass that estrogen blocker, that estrogen dam. So you mentioned, I think, Megan, you said that you don't know when it happened. And that's exactly right. It's not something that, when you look at PIK3C in initial diagnosis, we don't see it very often, because it's a bypass mutation. It shows up when you put a treatment in front of the cancer, because cancers are smart and they figure out ways around. And so PIK3C, we see upwards of 50% of the time once a woman's been on some sort of an estrogen blocker. And PIK3C is just one of many that are where every few months we're finding a new bypass.
And that's where we're finding some new treatments, right? That
That's
can
right.
outsmart the bypass.
Yeah, just a new one came out this year for PIK3C.
Yeah.
Wow. I know you got to go, but so you just got diagnosed. You're de novo metastatic. You're what do you ask your doctor for? Because we find so often, I always think you're in the dark. We're in the dark. We're always trying to reach out and give somebody a hand and say, here's what you ask your doctor for. So how do we help patients have these conversations with their doctors? Like, what should they ask for if no one's talking to them about it?
So I think that the simplest way to think about it is in the 3 layers. So you want to know the outer layer, which is your stage. So stage, it tells you something. It doesn't tell you everything. You want to know, the stage will tell you the cancer in the breast, where the lymph nodes are, and the metastasis. You want to know where that metastasis is. What does it mean when someone says there's a bone metastasis? I think people think about the back, the vertebrae is different than the ribs, is different than but it's all one organ. So you want to know, is it in your bones? Is it in the liver? The next layer is the receptors. So you really need to know, and you need to know what was tested, what was biopsied, to get those receptors. Estrogen, again, those 3, ER, PR, HER2. And if you're metastatic, if you're what you said, de novo metastatic is actually the official stage 4. If you want to be technical about it, that's the only stage 4. Is a de novo, someone who shows up at the door with metastatic breast cancer. And so both you can biopsy the breast, but you have to biopsy a site someplace else to prove that, because you can't assume metastatic. You have to prove it.
To prove it.
And that's what the biopsy does.
So you could have a lump in your breast, but you have to find it in your bones or find it in another organ.
Yeah, if you can safely biopsy it, you should.
Okay.
And then the last layer, the deep layer, is the genes. So ask about what sort of testing needs to be done for genomics, looking at the cancer's genes. There's lots of companies that do it. There's a few big ones out there that do it. Some large, if you go to a big center, like an academic medical center, they sometimes have their own internal testing. But whatever the case, if you're metastatic, there should be some sort of testing, if not right off the bat when you're diagnosed, at the very least soon after, if you're on some sort of treatment. But those are the main things. I mean, there's a lot of other information. I think familiarizing yourself with blood work, just having an idea of what that means when you're looking at a liver test, partly it's just not to get anxious when things change. You know, we get a lot of calls now because obviously everyone has access to their blood work and their tests, and you know, there's some minor changes, and sometimes people get really worried, understandably, but just understanding what that means and, you know, what to worry about, and just ask the doc, what are they worried about?
I have a question. When you ask for a biomarker, and how do you respond to doctors that push back and say, you don't need that?
You know, I think
You're fired.
my approach is, yeah, right. My approach,
You love the doctor, you've been
is
doctor
to, right. And I, you know, certainly there'll be times I'll disagree, but I want to, it's a conversation. This isn't, you know, this is not a one way, it's not a monologue. And so if a doc says you don't need it, they need to explain why you don't need it. What is it? And in a way that you can understand, because if you really know the topic, you're going to be able to explain it in that way. And it never hurts to get a second opinion. When you're newly diagnosed with metastatic breast cancer, having 2 sets of eyes from 2 different places, not the guy's friend down the street, but someone else, somewhere else, who just thinks differently about it. And you'd be surprised how often. And it's not because there's one right, it's just there's sometimes different ways to look at things. And so I love when, you know, I'm an opinion for somebody else and they see me periodically, but they treat it some way. It's just, it's extra sets of eyes and ears on the
I sent
case.
quite a few patients to you, Dr. Mehta, and they always have a good report that you explain
It's
things
good to hear.
But you know, I there's 6 words, right? How can we be more sure? Is a great way to just sort of ask if your doctor says this is it and this is what it is. But that second opinion will sometimes also allow you to hear it again. It may be that this was in your pathology. It was explained. It was, and you can't hear and process everything at one time. And so these conversations are never one and done either. They're really iterative, like they happen over and over again as you kind of get through the layers of what's my diagnosis. Okay, so what does this mean for my family? What does this mean for my FML? What paperwork do I need to fill out? What do I, you know, all that stuff. And then you're like, okay, so wait, what do I have? So what are these receptors? Okay, so then it really is the layers in the onion, like Dr. Mehta said. You know, you got to go through all of the different versions of understanding in order to even get to that point. But if a doctor just says no, you know, you can always say, how can we be more sure? How would this information help you if this were your loved one? What would you do if I were your loved one? You know, or just get that second opinion, you know, but asking the why may help you sometimes understand why not, because it may not change the management right now. This isn't a thing for now. This may be a thing for later. But explaining that and showing you guidelines and showing you where this information lives and how are they sourcing it, not just pulling it out of our heads, is a really great tool to build that trust.
Yeah.
And I will say, just the last thing here, that I think metastatic breast cancer is a marathon, and you're going to get to know your oncologist pretty well. And so you want to be as comfortable as possible. So trust your gut on that. I think that's why sometimes getting another opinion just to see how somebody else does something everyone's got their own style, even if they're saying the same thing, just in terms of how they respond to you, respond to questions. You want to be comfortable because you're going to need that team. And it's not just the doc, you're going to need the team, the nurse practitioner, the social worker, that whole team is part of your care. And so you trust your gut when you go in there that this feels like the right place for you.
I got a question for Jean. Why pick 3A? Why now? Let's talk about sort of what your understanding of what's emerging in the advocacy space to do this campaign and some of the motivation behind it.
Sure.
I'm going
Doc,
to,
I know.
Thank you, Dr.
I apologize.
Maida.
No,
Thank you
thank
so
you.
much,
Thanks for
Dr.
having
Maida.
me.
You have
Love
to
to be
come
back.
back.
Let me know when you
Yeah.
need me again. Happy to.
That
Sure.
was awesome. Thank you.
All
Come
right.
back.
Bye-bye.
Yeah, thank you so much. You broke it down so we can understand you.
Sure.
Thank you so much.
Go network.
Bye-bye. That's right.
Yeah, go network.
Yeah, no, great question. I think, you know, the No One Missed campaign actually started with lung cancer, raise awareness about biomarker testing, really in non-small cell lung cancer. And it was really successful in getting people to talk to their doctors and ask questions, very high level. And so Longevity, who really managed that campaign, talked to the advocates. I think Ricky was at the table, a lot of the patient advocates saying we want to expand to another cancer type. And did they think breast cancer was, you know, important? And I think everybody agreed. So, I mean, in listening to Dr. Maida and all of you, it is so complicated. And the more I talk with the media about this, there's so little understanding. And I think the only way we're going to break through so that the next person diagnosed who might be in somewhere without a lot of access, not with a specialist, is to make these words roll off the tongue and have people understand, like, breast cancer is not one disease. We've known that for a long time. It's not what your grandmother had. It's not what your neighbor had. You've got to find out what you have, and you've got to understand all the tests and make sure they're done
Right.
over and over again,
yeah,
especially in
and
metastatic.
make sure you're getting the test that you know that there's something out there that you need to know more about. And I think that's where I think, you know, doctors aren't asking us or telling us. And so it's kind of crazy that we have to ask for it, but we do. And so I think our purpose, you know, even in our show always is, okay, go ask the question. Don't be shy. You know, ask, you know, pursue, like, is my cancer different? Is my cancer, like, what are my biomarkers? Ask the doctors to make sure that they're treating you with the right information and the right, you know, the right treatment plans based on your cancer. And I think
Right.
everybody's cancer is different. We're
Yeah.
not a cookie cutter. It's not.
Absolutely. It brings up a good point though, Ricky. Somebody in the chat on Facebook just asked a question. How long do I need to be on this estrogen blocking
Yes.
pill? And I said it varies. And now there are tests that we can do to determine the benefit of shorter or longer endocrine or anti-estrogen therapy. Used to be everybody took it for 5 years, and then we went up to 7, and then we did some trials looking at 10. Now we can test your tumor's biology to see, would you benefit from shorter or longer therapy? So everything is getting so much more precise that it should be one of the questions in everybody's toolkit. How can I know that this is for me? What is the element of precision in this? Is there an element of precision that is possible? Like, how can we not just extrapolate from the guidelines of all the historic studies, but what about my diagnosis?
Right. And a few weeks ago, you know, we talked about doses, you know, with Stephanie and Julia, you know, about you know, patient-centered dosing. So all of these things are, you know, play a role in our care.
Yeah.
But, you know, so you guys, I think, you know, if you give an example of maybe, how did you make these conversations happen with your doctors? Did you initiate it? Did they initiate it? You know?
Yeah, Amelia, go ahead.
Yeah, I'll jump into this. Jean knows how much passion I have behind this. So I have, from the very beginning, had a phenomenal team of doctors. So wonderful things. But a lot of the things that you said here are things that I also did. I got the second opinion, and they were open to that. And that's another, I think, sign. If your doctor is discouraging you from getting a second opinion, to me, that's a huge red flag. My doctors encouraged it because it's also what you said, Dr. Mo. They wanted to also have another set of eyes. So all the advantage goes to getting more information. The other piece is, from the beginning, I have seen myself as a shoulder to shoulder to my doctors. So I am not asking, and I say that humbly, but I'm a
You
grown
can-
woman. I'm a grown woman, right? I didn't get this far by accident. So
That's
I
right.
think,
Own it. Yes.
right? I'm a
Yeah.
grown woman. And so I don't go into the experience asking, may I have this test? Like, that's not what it's about. So in the moment that, you know, and I think as a patient, you have to be unapologetic. You have to say, I want this test. I want to understand. If I want to get tested for something completely outside of that as a preventive component, that is my discretion because I'm the one receiving the treatment. And it's you know, I'm building my, you know, health portfolio, right? And
Right.
so I think that we have to stop, you know, patients should stop asking permission, you know, can I have that test? That you don't need permission from your doctor. What you need is to have your doctor understand that you're building your health portfolio, and as much information as you have in that portfolio, the better decisions you can make for yourself and your treatment.
And
Jean,
you're the CEO of your
Oh.
body, you're the CEO of your body, and you're actually paying a doctor to help you. You know, they're something that's supposed to be helping you. So,
Exactly right.
and the care you deserve. You go, girl.
Jean, I have a
Yeah.
question for you.
Sure.
What are insurance companies covering these biomarker tests?
Yeah, I was going to bring that up. So right now, Medicare does not, it's not mandated yet, and it is state by state. So not all states are covering this, and we don't have federal legislation. Now, what we're hearing anecdotally is that the tests are being covered, you know, whether it's the testing company has a patient forgiveness program, but I think, Megan, you have, maybe it wasn't you, Megan, maybe it was someone else I was talking to. Her doctor ordered genomic testing, biomarker testing. She's metastatic, and a bill popped up in her portal for $10,000.
Hmm.
Oh my
And
God.
she was
that
she
you,
didn't
Megan?
even know what to do.
Yeah.
Now this company, Foundation Medicine, ended up covering that, but it's so much anxiety. And what if that doesn't cover it? So we do need to fight that fight. The American Cancer Society and Komen are working on that. And I encourage people, again, this everything Dr. Mader was talking about, like the future is now. It's like amazing, right? Like it's happening now, but it's only happening if everybody can get access to it and it's paid for. Otherwise, it's not happening. So
Yeah.
we need to work on that. And Amelia, I just wanted to say, I know how passionate you are about dosing. So if you ever do that topic again, she has a lot to say.
Go get
Dosing and cadence. Those are
That's
my
good to
two
know.
Right. We talked
hot
about that
buttons.
with Stephanie Walker and Julia Moss a couple weeks
Yeah.
ago. Yeah.
This is the power, though, of advocacy, because we see that not just on the treatment side of things, but from screening as well, right? FDA, as of September 10th, we're telling women every woman needs to know her breast density, but we're not mandated by law to do anything about it or to cover the supplemental imaging in every state, right? Like there's so many areas where we're making these policies to inform, but not to follow up. And so we have to be these and it's why your voices are really so important and why this educational campaign is so important, because at some point we have to realize the cognitive dissonance of saying, yes, we're going to, you know what, biomarker testing, let's do it, and then not covering the drugs and not covering the testing and
not covering the testing, right? Not covering the testing
or the drugs, let's be honest, once you get
Oh,
there,
the drugs are tough.
the
Yeah.
most precise drug, right? You find that mutation and, oh, look at that, I got ESR, whatever, and it's not covered. It's not part of the guidelines. And now you got to either pay out of pocket or you have to fail on a treatment in order to get there. So so we have work to do, to get and it's not the doctors, it's the insurance companies, and I think the whole system but everybody's got to come to the table and be willing to have these conversations and get angry about it.
Yeah, and they've got to keep pace. The payers, the insurance companies have to keep pace with the science, and it's moving rapidly. Megan, I know I know you've been on a couple clinical trials. So Ricky, I know she's a girl after your own heart, right? So do you want to talk a little bit about like why you just jumped right from the beginning?
I love that.
Sure. I know that like the more lines of treatment that I have, the longer I can live, right? So if one treatment line doesn't work, I need to be able to hop onto a new one to keep my disease as under control as possible. So I really did my first clinical trial truly out of just necessity. I felt like it was a good idea. And then I had such a great positive experience with it, even though it didn't last very long, that I went on another clinical trial. And yeah, so I'm getting ready to start my third. It's really important to me. If there's an option for a clinical trial, I will absolutely do it. You know, I kind of have this philosophy, like until there's a cure, like use my body. I am so grateful for everybody who put their bodies on the line ahead of me that like I'm definitely willing to do it. And I received so many benefits from it. My quality of life in the past, you know, since 2020, since my diagnosis, since I've done these first two trials, has been really, really high. And the reason why I'm doing the next clinical trial is because it could provide, you know, another, you know, a really good quality of life. I don't have the drugs in my body yet, you know, it's questionable. But it's interesting because I literally met with my oncologist yesterday, and we did a biopsy, and it did mutate from like HER2 positive to HER2 low. So I'm very curious how that's going to work out. But then the interesting conversation that we had also was, you know, it's a short-term trial. Normally I'm on the last two trials go until my body exhausts them, until, you know, cancer starts growing, working its way around the drugs, basically. But with this trial, it's only 4 months long. It's a stage 1 and it's a phase 1 and phase 2 trial. I'm on the phase 1 part and it's only 4 months long. And she said, because these drugs, even though they're FDA approved, they're not approved together. So if you are doing really well in these next 4 months and you want to continue on to them, you just need to be aware that you're going to have to find a way to pay for them or get the drug companies to help cover them because your insurance will not. And so that's like a real, I was like, listen, I'm crafty and I can find a way. But some people cannot, you know, some people don't have the time to dedicate the research to do it.
They don't have, but I mean, I think you are very resourceful and you will find a way. But I think, again, though, you're the CEO of your body. You've got to take control of it and just know that you can figure it out and get the help that you need. And, you know, that's not even what we help you do. If you need to be in a trial and you need help, we'll try to figure out how to help you get the meds you need, and especially if something's working for you, you know?
I know, right? And I do feel like, you know, a lot of us that are advocates, you know, we know how to speak out. We know how to ask those questions. I would just say for people that are listening that are not that brave in that room and, you know, look at a white coat and go, oh, they know everything more than me. Whatever they say goes. I'm not going to ask my questions. Just bring somebody with you. Bring that friend that will ask those questions. Bring in an advocate with you. Find a friend of a friend, somebody who is like not afraid to ask those questions. Will literally just, no, you can't leave. I have 3 more questions for you.
Take your hand off. You take your hand off that doorknob, right?
Yeah. Come back. I got 2 more.
I know.
I'm going to go with Megan.
Yeah, I'll come with you.
No, I know. We wish the doctor was like Mo, you know, just spend and get love. But they're not. And you know, you guys are badasses. I love how, you know, you're taking control. And we actually had a conversation with one of our metastatic blesties last week, and she was talking about, someone came up to her and said, well, how are you stage 4? You don't look like you're sick. You know, and I think that you guys put another, you know, you look at stage 4, you know, that you can live. You said you have a good quality of life, you know, Megan, but I think
actually, Ricky, I use that quite a bit when people tell me, you know, I have stage 4 and they start falling apart. I'm like, oh, hold on. I'm stage 4. Look at me. 8 years. Yeah, the first 5 years was tough, but after you get over that hump, don't give up, because your life will continue and you're going to get that quality back. So no, it's not a death sentence. You can continue life and you can have a good quality of life. And I give myself as an example.
And you just moved to Puerto Rico.
Thrivers, Betty. That's why they call you thrivers. Absolutely.
Yeah, that's right. We're thrivers. And we can teach others to be thrivers, right? That's why we're advocates. We're showing others how it could be done, and we're giving ourselves as an example to thrive and fight back and ask your doctor questions. You know?
But you're also getting good medication for your bodies and your cancer, you know? So think about all the women that just take whatever they're given
Mm.
They don't get the testing. They don't know what their biomarkers are, and they're given whatever chemo is like the doctor recommends, and they're not having as great outcomes. You
I
guys are
see a lot of that here on this
Right?
island, and it's like,
Yeah.
no,
Yeah,
God, it
and
drives
some
me
of that,
nuts.
you know, I'm from Cuba, so some of that's also cultural. You know, you see
Yes.
this, and you mentioned this, Ricky, you said, you know, you see the white coat, you know, but I think what Dr. Mo
Mhm.
said earlier is really important, which is, you know, you've got to be able to know that it's you, like you are the person.
Right.
You know, it's almost like you have to think about it from a customer service standpoint, right? I work for big companies, and companies see the customer as like number one, right? And I think when you go into your doctor's office, you're the customer. Right. So
right.
the
right.
service that you
Amelia,
receive.
do you speak
should be that.
Spanish?
I do. It's my first
Oh
language. I had to learn
boy,
English
you're
when I
gonna
came to
be
the
on my
United States.
next learning
know.
series.
There's a Spanish question in the comments. Let me see if I can find it and I could send you guys. But
I'm calling you.
I don't think it's
Absolutely.
related to
but
the
also you
subject,
guys,
but I
you know
do
what?
have a question.
Oh,
Oh,
I was
sorry, go ahead.
say one thing, you know, you're not going to buy a pair of shoes that don't fit.
Some
You're
people
not going to buy it
do.
from a nasty salesperson. So if you go into a store, it's a great
Right.
analogy. If you go into a store, I worked in retail many, many years. If you go into a store and the person is impolite to you, you are going to say, that's not acceptable, and you're not going to go back there. And then
Exactly.
Mhm.
You're not going to buy the shoes. So same
Yeah.
thing. Why would
Yeah.
you put a drug that doesn't meet your cancer's needs in your body?
You
Mm,
It's a lot of
can't.
fear, though.
mm.
So,
Right.
so Jean, I have a question for you because with all these badasses on this call, there's got to be marketing materials, there's got to be a toolkit, there's got to be some resources. Like
Right.
these voices will not be silenced and should be shared broadly with
Right.
everyone.
Absolutely.
So what's in the works? What are you cooking up in terms of resources?
Yeah,
Mm.
so if you go to the No One Missed website, which is noonemissed.org, and you just click on the metastatic breast cancer link, there are 2 different downloadable fact sheets. So interactive, lays out the mutations, the questions to ask your doctors, and Dr. Mehta just did a 10-part video series. So super short, 2 to 3
Wow.
minute videos. One's 4, I think, answering all these questions. So those are already on Living Beyond Breast Cancer's YouTube channel. You can see them there, but they'll be on the No One Missed website. And
Right.
we will be rolling this out as we go into the fall, doing something you know, big on Metastatic Breast Cancer Awareness Day, which is October 13th. And then on Living Beyond Breast Cancer's website, we have deep resources on biomarker testing, but we want people to just sort of learn at their own pace. So maybe like get familiar with the terms, and then how much more do you want to learn? Megan and Betty's profile they're on the website, and we'll be rolling out more profiles. Amelia will definitely get you up there too. So
Right, and your website is livingbeyondbc.org.
it's just lbbc.org,
Oh,
and
okay,
then No One
LBBC.
Missed.
Okay, I got that one. Yep. Okay.
NoOneMissed.org.
Mhm.
Yeah. So this is just so important. I mean, I think what Dr. Mehta was saying, you know, if so much has changed in such a short period of time, and if we
Yeah.
gotta like get on it and be a part of it. There's just a lot of opportunity, but it's complicated. And I think if you're seeing an oncologist who's not a breast oncologist specialist, which I'm sure
Yeah.
many people are seeing a general oncologist,
Yeah.
that's where we would suggest definitely having a second opinion with someone who specializes, who's going to the meetings. Because I don't know how general oncologists can keep up with all of this.
I know.
You know
Yeah.
what, here in Puerto Rico, when I do see an oncologist, and this is why I started flying back and forth more often for my treatments, she's a general oncologist, and she didn't even know half the things that needed to get done to, you know, follow up with my treatment. And I'm like, oh my God, no wonder people are dying on this island. You know,
Right.
they don't have the specificity with breast or prostate or liver. They're just general. And, you know, we all know that cancer is not the same.
It's not the same.
It's not the same. And, you know, not the same for individuals and not the same across the board.
Right. It's not the same. And it's too bad that we have to figure it out for ourselves. Or
Yeah.
you know, but
Yes.
that's
And
why,
figure it out for some
Yeah, that's
doctors
right.
too.
yeah, we need to help people or help our doctors understand our cancer. And I think that this is such a great discussion. Thank you for doing this with us today. But I think it just, you know, no is never the answer. It's always how. Go figure it out. You know, one of my favorite things, everything is figure outable, and don't take for granted that your doctor knows what they're talking about, because they may, and challenge everything, you know. And if the
And don't
doctor,
apologize for asking questions about your care.
exactly,
Don't
Join
do-
support groups.
yeah,
Yes.
the support groups. And I know, actually, Betty came to our TNBC support group last night, you know, so we do 2 a month, one for TNBC, one for everything. It's this Saturday, actually, Saturday at 11 Eastern time. But I mean, we have to support each other and learn from each other, and
Mhm.
know that, you know, you're the CEO of your body.
Yeah.
Right?
So are all of you on social media? How can people follow you in your advocacy work? How can
Yeah.
we support you?
I am on Facebook and LinkedIn and X.
Under your name, Amelia?
Yeah, I do. And I have a website that I created just based on my own story. It's called thebreastcancerguide.com, How to Breast Cancer. And again, it's really my lived in experience with a lot of the things that when I started going through this 5 years ago, it was so overwhelming. And my intention was really to just put information out there and share my information so that others could benefit from that as well. So we
Oh.
post articles and stories, and that's how I, got to also meet Jean and all the great people at LBBC. So
And what is your website called again?
it's called thebreastcancerguide.com.
And I have Ricky's.
Yep, I'm putting it on here, breastcancerguide.com.
Thank you.
Yeah, I'm on Instagram and Facebook, and I even tried a little stint on TikTok because that's where all the young kids are.
That's
And,
right.
as someone who was diagnosed so early and was told that I was so young, I'm like, that's where I gotta go. But
Megan, what's your Insta?
yeah, so it's me, like M-E, me, and then again, and then O'Neill, O-N-E-I-L, me again, O'Neill.
O'Neil, got it. Okay.
How about you, Betty?
Facebook, Bet Sanchez, LinkedIn, same thing. Yeah. But I definitely want to do a website, but I'm old. I have to learn how to create one.
You are never too old, baby.
I'm not
You
young
are-
like Megan. I
You
need
are
Megan's
never too old.
brain.
You're good. You're good.
Yeah.
I'm gonna tag along Megan. Come on, like a vampire. Give me some of that young blood.
I'll give it to you. I'll give it to you.
You guys are awesome. Awesome, awesome, awesome. Thank you. Thank you.
Thank you,
so much.
Jean,
Thank you.
our CEO.
Yep.
Yeah.
Thanks for
Thank
bringing
you.
this to our attention, and
Yeah.
we look forward to promoting more resources and more awareness about this,
Yeah.
because
we
Thank you,
definitely-
Dr. Mo.
Oncology story. It's my privilege. It's not a one and done. It's an ongoing conversation, because
Yeah.
we're in the era of precision oncology, and we really have to do everything we can to make sure that that includes all of us, right?
Yeah.
Not just some
Yeah.
of us, not just
Thank
those
you for
that
being patient with us.
not just, oh gosh, you guys are hoot. You're so much fun. It's my favorite time of day, Wednesday night, 6 p.m. here on blackdoctor.org. It's what we do, right, Ricky? Every Wednesday.
Every Wednesday, we do it every Wednesday. We're so grateful to Black Doctor for the platform, so grateful for our sponsors and supporters, and so grateful for our friends that we can call on and get information. So you guys are now in our family. We won't let you go. And we should have this conversation again in a few months, and
Yeah.
see. So people
Thank you,
just
Ricky.
let's
Thank
plan
you.
that for maybe the first quarter of the new year, and let's talk about it again and to help people get this, because you know what? I think about this every day. When I wake up in the morning, one of my first thoughts are, we have new customers every day. Every day, somebody's going to get that call every day.
Yep.
You do have breast cancer. And so we can't talk enough about the same stuff. Do you know what I mean? Because
Nope, you're right. And everybody, I just talked to someone yesterday, DCIS 5 years ago. She's metastatic. There's my dog.
I know, another doggy.
yeah,
And
Yeah.
same questions over and over again,
Over
but
and
like
over
you
again, every
gotta
day.
just say it over and over again. This is what you have to ask. This is, so yeah, you're right. You just gotta keep doing it.
we're doing it. And that's one of the things that, we have a library of all of our episodes. So this will go into our library. Well, it's on Facebook in perpetuity. It'll go on our YouTube channel. So when people want to know, you can just say, hey, here's the link to the video, and
Love it.
you can learn. So we'll
And
just-
not only talking the talk, but
Yeah.
walking the walk,
Walking the
right?
walk.
Because coming up next, we're talking about feet.
About feet, that's
Gotta
right.
put in a
About
plug. I
feet?
had to do the,
What?
you saw what I did there, right? You saw what I did there. Dr. Corda Dakota, right? Dr. D, she's talking about pigeon toe, flat feet kids, ingrown nails. Do kids walk on their tiptoe? Like, how do you know as you get back to school that your children's feet are in order? So
Yeah. Next.
we're talking the talk. She's walking the walk. Coming up next on blackdoctor.org. Stepping in, what is it? Stepping forward with Dr. D.
Dr. D.
Wow, that's so important.
Yeah, yeah, she's our blessed friend.
That's right. That's right. So stay tuned and support my soror posse. That's my sorority sister. And she has a story to tell. But thank you all so much for joining us.
Thank you so
Wanna
much.
do this
Thank you all.
in the spring. Let us know what you find at San Antonio so we can recap and invite you to talk about some of the things you learn. Like I would love to have you all come back and talk about the different conferences and the data and some of the things that you are learning just as an advocate about this field. And it's going to be so enriching, I think, for everybody.
See you in San Antonio.
See you in
Yeah.
San Antonio. All right, you guys.
Peace.
Bless, love.
Here
Thank
it
you.
is.
Love you
Wait a minute,
guys.
how do you do that? Like that, right?
Yeah, yeah.
Just
Bless
put
you,
two C's and put them together.
Love you, Mo.
Love you too.
Bye.
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 Bye. Take care. Bless.